first trabectome surgery, joining thousands of surgeons worldwide who are doing this elegant procedure. Hi, I am Dr. Sahebaan Sabharwal from India. As a beginner myself, I would like to share my tips and experiences to help and encourage young surgeons to take the plunge. In this short video, I am going to discuss a few top tricks that I wish I knew from the start and hope that it works for you too. So, when you're just about beginning trabectome surgeries, you want to select good candidates to ensure uneventful surgeries and good results that will keep you motivated. Trabectome surgery can be done either as a standalone procedure or in conjunction with cataract surgery. So, you're going to be looking for a patient with open-angle glaucoma who can be pseudo-phakic, phakic, or have a visually significant cataract. The ideal stage of glaucoma is early to moderate glaucoma. As for the intraocular pressure, it should be either controlled or uncontrolled with one or two medications. Basically, the goal of the surgery is to reduce IOP by 20 to 30% or reduce your number of medications by at least one. At this point, it's very important to get comfortable with the basics of angle surgery. The surgeon needs to be positioned temporally in order to treat the nasal angle. The patient's head is tilted 35 to 45 degrees away from the surgeon, and the microscope is tilted 30 to 45 degrees towards the surgeon. So, what are the cases that you want to avoid as a novice trabectome surgeon? If on gonioscopy you see significant high peripheral anterior sinus gaze, especially in the nasal angle, this is likely not a good candidate. Try and avoid neovascular glaucoma cases, patients with corneal opacities obstructing your view, patients on anticoagulants as your first few patients. It's imperative to familiarize yourself with the machine at the outset. The trabectome unit has a unique handpiece that allows for continuous irrigation, aspiration, and controlled ablation of the trabecular meshwork tissue. It has a foot plate which activates the ablation, and a black ball pedal is pressed to activate continuous irrigation. Then there is the electrofluidic base system. Start your surgery with a very good visualization first of all. You must have a good microscope. If you don't see well, you're bound to not have good outcomes. Don't use viscoelastic prior to trabectome. You can create a blur or generate air bubbles and make it harder for you to identify the trabecular meshwork. Now, since the most important step of the surgery is identification of the trabecular meshwork, an important tip in this direction is induce hypotony by burping the paracentesis incision so that you can visualize blood in the Schlemm's canal and be sure to be in the right plane, and not ablate the ciliary body and end up with devastating complications. Let's look at the technique, and now let me give you a few surgical pearls that work for me. Your 2 mm incision has to be more anterior than what you would like for a cataract surgery. What you want to do differently over here is flare the internal lip of the corneal incision to ensure a wider treatment arcade. Do the trabectome surgery before phacoemulsification. This ensures a well-formed anterior chamber through only a paracentesis incision as opposed to a wider corneal wound created for a cataract surgery that would lead to wound leak and unstable anterior chamber. Note that whenever you face resistance to advancement of your handpiece and the eye rotates along with the probe, your tip is probably inserted into the scleral wall. Stop and reposition. Ideally, there should be no resistance of trabectome tip as it strips the trabecular meshwork. What are the potential risks that you need to be aware of? The common concern that this procedure shares with any other angle procedure is that of bleeding, prolonged inflammation, and scarring of the angle. Bleeding is expected during the procedure during deroofing of the Schlemm's canal with resultant blood reflux that occurs in the anterior chamber. Post-operatively, it is common to have mild hyphema, and typically it clears with time. There is rarely a need to clear the hyphema surgically. Prolonged inflammation can pose an issue because it can lead to prolonged use of steroids, thus creating IOP spikes, and also by causing angle scarring, which if leads to anterior synechiae can close off the cleft created by the trabectome procedure. So the following few steps after trabectome surgery can help minimize these complications. So at the end of the procedure, close the eye and make it watertight. You should leave about 30% viscoelastic in the anterior chamber to help tamponade the ablation site and minimize reflux bleeding from it. In the end, it's extremely important to counsel your patients well. Prepare them for a few days of blurriness and taper off the prednisolone quite quickly. Prefer to use post-operative pilocarpine in my patients about 4 times a day for a couple of weeks to help keep the iris away from the treatment site. So finally, let's look at the success rates of the procedure. Since this procedure has been around for a decade, there are several papers that have validated its efficacy and safety in all stages of open-angle glaucoma. Notably, an article that evaluated 4,659 trabectome surgeries and a 90-month follow-up found an 85% survival rate of trabectome surgery when performed with cataract surgery at the end of 5 years and a 66% at the end of 7 years, with an average IOP reduction of 30% and 60% reduction was found in glaucoma medications.